And share my screen. So today we'll be talking about prescribing memory medications. So the purpose and value of these medicines. We'll have a separate talk on behavioral symptom medications next week. So this will be focused more on the cognitive side of things. So we'll take a quick look at the FDA approved drug timeline. When do we recommend starting medications? Slightly different than kind of the FDA approved guidelines. And then some tips for dealing with side effects, which are very common with a certain class that we prescribe, when to stop medications, and then we'll have a brief discussion on the anti-amyloid therapies with obviously Dr. Burns's discussion a few pocket talks earlier. It has a lot more in depth on the anti-amyloid therapies. So disclosures, just as I mentioned, I will be discussing some off-label use, specifically the use of acetylcholinesterase inhibitors in mild cognitive impairment, as well as in patients with Lewy body disease. So when we look at the timeline of things, obviously it's a barren landscape as far as medicines that have been approved for dementia in general, and especially Alzheimer's disease. The first medication that made approval was donepezil in 1996. There were some earlier acetylcholinesterase inhibitors, which is what this class of drugs falls in, but this was the first one that was approved based on efficacy studies. Rivastigmine came later, and then galantamine. These are all under the same umbrella of the same types of medications that work the same way. Memantine is a medication that basically works within the NMDA receptors, but exactly how it works, we don't fully understand. There's a combo drug version which can reduce pill burden, but is more expensive. There's then the class here on the right side, the newer approvals that are the monoclonal antibodies. So we'll kind of walk through each one of these and how we use them in the memory clinic. So when we first think of when to start medicines, I think it's nice to just think of, we're dealing with a disease that is progressive in nature, right? We don't have any medications that reverses this course, but our role and our goal in starting these is to try to slow that down as much as possible, right? In this mild cognitive impairment, mild dementia stage, which I've kind of outlined in blue here, this would be where you'd want to be considering the newer therapies, although that is still controversial. So we can certainly talk about that, but that's what they're approved for, is this stage. This is also when we definitely need to be starting our cholinesterase inhibitors, particularly to try to sort of create some amount of stability in cognition. And it's still going to get worse with time, but try to slow that process down. We even see some patients, especially in Lewy body disease, where there's a significant increase in their cognition. Once we're reaching more of moderate dementia stages, that's where we consider adding in memantine. Usually this is more for behavioral symptoms rather than cognitive, but there's might be some slight benefit from cognitive as well. So we'll talk about that in a little more detail later. When we think about the cholinergic hypothesis in Alzheimer's disease is long-standing. It goes back to even the 1970s and early 80s. But the idea is, so acetylcholine is a really important cognitive neurotransmitter. It projects throughout the brain. It's really important for your working memory, for focus, and for the memory system in general, and the attention system. And one of the key regions that gets affected in Lewy body disease and in Alzheimer's disease is this green blob right here. And so this is the nucleus basalis minor. That gets decimated in these diseases. So we see a lot of damage to these structures. And so then you're getting a lot of loss of acetylcholine projecting out to the brain, which drives some of these cognitive symptoms we see. Acetylcholine is basically released out, and then it ends up getting broken down in between the synapses to recycle things. And the goals of these drugs are to basically block that breakdown. So we're dealing with someone that has less acetylcholine in the brain, but we're trying to keep it around longer, right? That's how these drugs work. And so the goal is basically to try to give some sort of supplementation, right, of acetylcholine in a disease that is suffering from loss of acetylcholine. And so what's the inverse of that? That is blocking acetylcholine, so anticholinergics. And this is why we stress so hard to make sure your patients are not on acetylcholine blocking medications if they have memory concerns, right? So we have lots of reasons why we prescribe these, but you have to think about the risk and benefit. There's been multiple studies looking at anticholinergic use causing, being associated with, I shouldn't say causing, but being associated with worsening cognition, changes in brain metabolism, changes in brain atrophy, even in cognitively normal older adults. So that's why many of these medications are on the, the Beers list of medicines that you shouldn't be prescribing, or at least should reevaluate prescribing in folks 65 or older. There's a long, laundry list here. This is being recorded. You can always go back to this. I'm not going to go through all these. Here's some more common ones that are prescribed. I think it's helpful to have a tool, right? So you can quickly type in on a website, nice, easy to use website, acbcalc.com. What is my patient's anticholinergic burden scale, right? So I just went to this website, created a quick little video, right? So you can just go in and type in a medication. Here's a common one we see prescribed: oxybutynin, paroxetine, right? And then tizanidine, so that's a muscle relaxer. And then commonly one that's not prescribed, but somebody taking over-the-counter sleep aids like diphenhydramine or Benadryl. All these are highly anticholinergic. If you have a score of 3 or higher, that's already considered a high risk. So if you have someone that's on multiple versions of these, then you're certainly going to reach significant compromise of someone's cholinergic system that already is weak in that system, right? So that's the major takeaway point there. I do have to mention, so I will be saying that I commonly prescribe these acetylcholinesterase inhibitors to patients with mild cognitive impairment. That goes against the practice guidelines, even from the Academy of Neurology, the American Academy of Neurology. So, from their 2017 and 2018 statements, basically, the idea that, you can choose not to offer them an MCI is level B evidence. And then if you do offer them, it is considered off-label, right? This data basically came from one large study from the Alzheimer's Disease Cooperative Study. And when I looked into that study, and someone else has actually published a paper on this, 30% or a third of the patients were misclassified as mild cognitive impairment. So this is a really busy figure, but basically the takeaway here is if you score below minus 1.5 standard deviations on cognitive testing, we consider that to be in either the borderline or abnormal range. If you have folks that are scoring on the memory testing in the abnormal range here, this is about a third of the group. This is what we call single domain amnestic mild cognitive impairment. It's pure memory loss here, right? So this is like what a classic Alzheimer's patient would present as early on in those early stages. Here's where we see multi-domain. So we're getting a couple different of these cognitive tests abnormal. So that was a good majority of the patients. But there's a group that were labeled as MCI that technically their cognitive testing is normal, right? And as we've talked about in prior pocket talks, right, those patients probably have what's should be termed as subjective cognitive impairment. They're noticing symptoms, but on objective testing, we don't see abnormalities, right? So this is a misclassification. If you remove that misclassified group, right, at every level of donepezil versus placebo, there is a statistically significant difference in the decline rate over time, so over 3 years. So there, and just think about it logically, right? It doesn't make any sense to wait until someone has dementia due to Alzheimer's versus mild cognitive impairment to start supplementing acetylcholine. I think the problem, right, is diagnosing early Alzheimer's at mild cognitive impairment is very difficult. That's why we're giving all these talks, right? That's why we need to use better tools. This is why we have a specific talk on mild cognitive impairment, because there's lots of different causes of mild cognitive impairment. But if it's due to Alzheimer's, it makes sense to have your patient on a medicine that helps with those symptoms specifically. Here's just short-term data, right? Most of the studies on these drugs are short-term data. So placebo, clinical decline versus on drug, very statistically significant difference. Here's one where there was actually improvement in scores in the donepezil group. What we didn't have for a long time is long-term data, right? Um, and so now we do have pretty good data. There was a paper published in 2021 that used a really extensive Swedish dementia registry to look at patients that were on drug, on any of these anti-cholinesterase inhibitors versus not. There was an overall reduced mortality across the board, with galantamine being slightly higher than donepezil. There was reduced conversion to severe dementia. These were, you know, close to statistically significant, but galantamine in and of itself did reach some significance. A 2022 study out of China had 13 years follow-up. There was slower decline in cognitive scores, but also reduced mortality on these drugs. And then we've had a meta-analysis published in Brain in 2022 where multiple studies were looked at that show long-term data, most of these kind of 3 to 5 years. So, you know, should my patient be on an acetylcholinesterase inhibitor? I will say emphatically, if they have Lewy body disease, whether it be early stages or not, that is an absolute yes. For Alzheimer's disease, it's a definite yes as well. We find in our practice that the young onset, working memory, or dysexecutive variants of Alzheimer's respond much better to these medicines than not. And when you look at the neuropathologic data, it's the young onset dysexecutive folks that have that nucleus basalis minor hit even harder than the classic, you know, older amnestic variant. But it still benefits patients across the board with Alzheimer's disease. For that MCI stage, I personally say yes, right? Although I will admit that is off-label. For vascular disease, so patients can have dementia or cognitive impairment due to vascular disease. You know, we say probably not. However, when we look at the data, right, the reality of the situation is, you look at the autopsy data, somebody that has like pure vascular disease, that's the only cause of their dementia syndrome, it's pretty rare. So there's a large overlap of patients that have Alzheimer's and vascular, or vascular and Lewy body. So we sometimes still will trial it, even if we're pretty convinced this is all vascular, just to see if they get benefit, but with kind of a quick leash on that drug to take them off if they're not getting benefit. And for frontotemporal disease, the answer is no. So they don't have damage to that nucleus basalis minor in most cases. And if anything, we see sometimes worsening of behavioral symptoms on these drugs. So some tips, because these you know, do have significant side effect profiles, specifically when we look at the GI system. And if you prescribe it at nighttime, it can very often worsen nightmares and insomnia. So we recommend prescribing it in the morning. This should be with a meal, especially a high protein meal, to try to help reduce GI side effects. You want this drug kind of peaking throughout the day while someone's brain is active rather than at nighttime. But you always have to start at a low dose. So sometimes we even go as low as 2.5 on somebody that's, you know, say smaller in size or has a more sensitive stomach. But for most patients, we start at 5 for a full month and then increase to 10. Let's say they did fine at 5, but then once you increased it to 10, they got the GI symptoms. Well, then get creative with the medicine, right? Split it between morning and dinner. That works in the vast majority of patients to try to still get 10 milligrams throughout the day, but not hitting the stomach all at once. We do push the doses beyond standard dosing. So especially in Lewy body disease or in these young onset Alzheimer's cases. But the only way we can do that is if they tolerate it. Lewy body disease is a little bit easier because part of the disease process in the vast majority of patients is having constipation as one of the symptoms. And so we can generally make them more regular without causing the diarrhea side effects. There is a 23 milligram sustained release tablet out there. I've never prescribed it. It really has the same bioavailability as if you get up to 10 milligrams twice daily. So that is an option though for patients, usually more expensive option. Galantamine has both a twice daily version and an extended release version. We primarily use the extended release version if we're going to be prescribing that. I don't ever prescribe rivastigmine oral. Some neurologists do. The side effect profile of it is extremely high, and it's because it peaks so much and then it wears off, and then you have to take it twice a day, and it's these peak effects that causes the side effects. Whereas you see these patches are a much smoother release of the medicine over time pharmacologically. So rivastigmine patch works quite well for the GI side effects if someone's experiencing those, and these are the typical dosing that we use. The main issue with the patches is skin irritation. So allergic reaction is quite rare, but contact dermatitis is pretty common, especially in patients that have poor skin care, have a lot of dry skin, right? So there's a lot of different tips for skin care that should be recommended in those patients. So, I think it's important to counsel patients on why these medicines have side effects. So acetylcholine is responsible for helping peristalsis and digesting your food, right? So moving things along in the stomach. And we're basically increasing acetylcholine, right? So especially if they take this on an empty stomach, their stomach starts moving things along that are not there. That's going to contribute to nausea, vomiting, diarrhea. And so when we look at the side effect profiles of these drugs, the rivastigmine oral that I told you about, the side effect rate is somewhere between 40 and 50% of patients will get that, especially once you get to higher therapeutic doses. Donepezil is about half that, but it's still a considerable amount. Galantamine extended release is a little bit less, with rivastigmine patch being quite a bit less, right? So we do see muscle cramps in some individuals. This is much more common in donepezil than it is with the patch. We see nightmares and insomnia worsen if prescribed at nighttime. And then you have to think about the heart here too. So one of the clues could be, lightheadedness and fatigue, right? It could be that they're experiencing some side effects from the heart. And so especially patients that have a lot of cardiac history, they've got bradycardia baseline, they've got a known heart block, prolonged QTC, that's where we would, express caution, and you probably need to begin an EKG with sort of a steady state EKG after someone's been on the medications, and you have to be aware of some of these other drugs that contribute that patients get put on. And so if there's a lot of cardiology stuff going on, it probably makes sense to have a cardiologist weigh in, or at least follow these EKGs to make sure there's not any concerning features appearing on their heart tracings. So when should we stop it, right? I mean, certainly when the negatives outweigh the positives. However, I too commonly see them, donepezil getting prescribed, and then, it quickly gets pulled off without any other suggestions, right? And, so if we're seeing a lot of weight loss, if you're seeing anorexia, which weight loss can be as part of the disease process, but we might be accelerating it with nausea and upset stomach and diarrhea. If you start to get this lightheadedness fatigue issue, right, you got to be looking at cardiac stuff. But we should be trialing some other versions, right? Especially if it's GI related symptoms, then we should be considering the patch form or the extended release form. So should I be starting memantine? I will say up front, not as an initial primary medication, which I see this done all too often. And I think many providers that are doing this are treating themselves more than the patient, right? There are limited side effects with memantine, so you're not going to get phone calls about side effects, but it does not do much on its own. It is approved for more of the moderate severe stages. And what we see in the data is it basically helps most with behavioral symptoms that happen later in the disease course. It's, again, usually well tolerated. There is some cognitive evidence, but more of a synergistic effect with donepezil. And it's unclear if that's even clinically significant effect. In Lewy body disease, there's conflicting evidence. There's ongoing trials with it now. And if you ask any Lewy body expert, a third of us don't ever use it, a third use it regularly, and a third are kind of in the middle. And so there's not great evidence for it. And in frontotemporal disease, there's been no benefit across multiple trials. There is that combo drug I mentioned earlier. So we're going to have a whole talk next week on the management of non-cognitive symptoms, but I did want to mention that our first line agent for these symptoms is still the cholinesterase inhibitors and memantine. So those should still be thought of as the first line agents for behavioral symptoms as well. We're going to be talking about these medicines, though, in the next talk. So in the interest of time, I'm going to save that for next time. So the newest kid on the block are the anti-amyloid the monoclonal antibodies is what we call them. And so I really like this slide or this figure from Dr. Knopman's paper in neurology last year. We've had over 40 failed trials in the amyloid world of targeting amyloid. However, there's been a lot of different ways we've targeted it. And these trials that are showing some modest benefit, what stands out? Well, in both lecanemab and donanemab here in purple and red, we're getting significant amount of folks that are becoming amyloid negative. So if you take somebody from positive, you go clear it out with a monoclonal antibody and make them amyloid plaque negative. These are the only two drugs that have consistently done it in a high percentage of patients over time. A lot of our other failed trials, they didn't reach much clearance from making someone negative. The one that's kind of in yellow here was the one positive on the aducanumab side. So there may be something to that. There may also be something with how these drugs work differently from each other. So lecanemab specifically, since this is the one that's currently approved, it basically targets the amyloid plaques and amyloid fibrils and activates the immune system to basically signify on clearing them out. And so we can take this is an amyloid PET scan where there's amyloid filled throughout the brain. This is like a highly positive amyloid PET scan. And we can make it essentially negative where you see really no cortical amyloid. It's all in the white matter. The targets for this drug is the protofibrils that are sort of the early accumulation after oligomers, and then also the plaques. But it targets the protofibrils a little bit more. These are approved for folks with a diagnosis of mild cognitive impairment or very mild dementia due to Alzheimer's. Dr. Burns talked about this a lot more in a previous pocket talk, so I'm not going to go into full detail, but these are generally the scores that we're looking for. Folks that have scores a lot less than this are much more likely to have more tau in the brain, and we see less benefit for those with higher tau burdens. In order to qualify for these drugs, you obviously have to have abnormal biomarkers for Alzheimer's disease, either measured in the spinal fluid or with an amyloid PET scan. And then patients should not have evidence of, early bleeds in the brain or cerebral amyloid angiopathy, because these are the folks that are much higher risk for the side effects. What does the data show? So really across the board, there is a statistically significant slowing, right? No, this is not a cure or anything, but they're consistently across the board. When you look at different measures, CDR sum of boxes, multiple measures, we have a benefit over 18 months, right? However, right, we don't really know what happens after 18 months. We at least don't have published data on this yet. That data should be coming. But if this plays out where it's the same 30% slowing, which is basically the best case scenario over the course of the disease, I'm not entirely sure if this is going to be clinically relevant, right? What we need to see is, does this further slow things down over time because it's disease modifying, right? That's really the main hope with the anti-amyloid drugs, is that they are disease modifying over time. And we just don't have that data yet. And just to highlight why you should be having your patients on donepezil more than referring for them for monoclonal antibodies, like this was the same ADAS-Cog that's measured here, right, of benefit short-term with the donepezil medication. What are the side effects? Well, the main one is if you activate the immune system in the brain, you can overactivate it, and then you can get swelling in the brain. And these are usually the folks that will develop some symptoms, but a lot of it, 80% of folks will never have symptoms, even up to 90%. But when we see this on our surveillance MRIs, we stop the drug, we let the immune system calm down. We have ways to manage this, especially in the asymptomatic folks. There's also little small microbleeds that we see. Now, some of this is part of probably the disease process as well, which we'll highlight on the next slide. When we look at the overall data, so even in the placebo group, 9% of folks developed this amyloid-related imaging abnormality. Most of those are in those little small microbleeds. And so this is probably just disease progression, right? but there was obviously higher amounts in the drug group. Again, is usually asymptomatic. Serious ARIA events were rare, but they're there. And 3 patients died in these trials where at least some amount of the drug was to blame with this. These are the common symptoms we see. Again, they're pretty generalized, right? But it would warrant, if somebody had these symptoms, it would warrant us to do kind of an emergent MRI to see if this ARIA was developing. Um, we recommend checking ApoE status because it has a pretty big predictor of who is higher risk. And so we know that ApoE4 is a risk factor for Alzheimer's disease, but it's also a risk factor for cerebral amyloid angiopathy. And so when we look at the E4 carriers versus non-carriers, the ARIA rate is similar. But the E4 folks, it is significantly higher, right? So the folks that are that have 2 copies of E4 have a significantly higher ARIA risk. And so while this is not a standard practice for genotyping folks, if they are going to be put on or considered for lecanemab, that really should be done. So consider how you'll disclose that information, right? So when we look at kind of like the overall risks and benefits, right? We see statistically significant slowing across multiple measurements. We actually, and I didn't discuss this, we see benefits on downstream biomarkers, particularly the good amyloid and the bad tau. There's a lot of burden. These are not very practical drugs, right? You have to come in every 2 weeks for an infusion. And then you have to do 4 serial MRI scans for the first, 6 to 12 months. You have to get kind of all the pre-workup too. It's an expensive drug. It is covered by Medicare, but if everyone on Medicare went on this drug, it would bankrupt Medicare, right? All of our premiums would increase. So cost is something we have to consider even with insurance coverage. And then there's the safety, right? So these are obviously not benign drugs either. We're activating the immune system. That's a pretty big deal. It's not a cure, right? And then, even though there are statistically significant benefits, is it clinically significant? So that is an ongoing debate within the field. And my main thing is what happens after 18 months, right? So that's a really big point that needs to be answered. And then, so just to highlight the cost, right? So who's going to pay for this? Well, CMS and Medicare is if someone's enrolled in a research registry. So we're trying to track all this stuff in high level of side effects and benefits versus risks. When it's not Medicare, so private insurance companies, we've seen some kind of mixed coverage of this. And so then the last slide here, there's obviously a lot of challenges whenever a new drug comes to market, but this one is pretty highly specialized, right? There's too few of us cognitive memory specialists out there. And then identifying the appropriate treatment candidates is hard. There's a lot of workup that goes into it. And then and our anti-amyloid clinic takes care of all that. We do the workup, but a lot of patients would never have qualified for the research study. When you look at kind of like a population level data, there's a large exclusion criteria for these trials. So many folks won't end up qualifying. In our experience may sort of increase, part of when a drug comes to market, we have to expand that usage criteria, and maybe we'll get more comfortable with a larger patient population, but that's to be determined. So I will go ahead and stop there. I think we're right on time, but I'll